How's it going, guys? Now, this is one of the most frequently incorrectly answered questions on USMLE for steps 1 and 2. This is not going to be a lengthy clip. I will tell you exactly what you need to know and not waste our fucking time. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. And find me on Instagram at Mehlman_medical, MEHLMAN_medical. The link is down below. And find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. 38-year-old man, he's in a motor vehicle accident in which he sustained significant blood loss. Blood pressure is 70/40. He's resuscitated, receives multiple packs of RBCs. 24 hours later, he develops oliguria. Serum potassium is elevated. Coombs test is negative. Question wants to know the most likely diagnosis. So elevated potassium in the setting of oliguria, this is just renal failure. Clearly, it's acute renal failure. The negative Coombs test means we do not have antibodies against RBCs. So let's just walk through the answer choices. We'll go backwards. Choice E, renal papillary necrosis, wrong fucking answer. This will be the answer on USMLE if you get a patient who has sickle cell plus dark urine or NSAIDs plus dark urine, okay? 9 out of 10 times. And I don't even believe I've seen this 10 times across NBME material for step 1 and 2 because it's that fucking low yield, okay? But I'm just telling you, if you say, when would that be the answer? It's going to be a sickle cell patient or a patient who's on NSAIDs plus dark urine, okay? It's all you need to know. It's just an ischemic condition of the kidney. Choice D, prerenal azotemia, wrong answer. Now, this is immediately where it's like, ooh, wow, why is this wrong? Because students will say, I don't get it. Isn't prerenal azotemia when we've got reduced perfusion of the kidney followed by renal failure / insufficiency? Isn't that what prerenal is? Why would this be wrong? I'll tell you. And this is, as I said, that students get this wrong all the time. It's because acute reduction in perfusion of the kidney causing ischemia, acute ischemia, i.e., blood loss due to trauma, surgery, an episode of ventricular fibrillation for 30 seconds where there's a loss of perfusion of the kidney. This causes acute tubular necrosis, not prerenal azotemia. And this is because the proximal convoluted tubules have a high density of ATPase pumps that have high oxygen demand. And the PCT is most susceptible to anoxic injury of all places in the kidney. That is asked directly as well, exceedingly high yield, okay? That you know the PCT is most susceptible to anoxic injury. This is acute tubular necrosis, this question. They asked this directly in a one-liner on I believe it's offline NBME 24 for step 1, but they integrate this concept all the time into larger questions. 2CK, they'll give you a big fucking 12-line paragraph where all they're really telling you is just dude had blood loss from trauma, and then you can just see with all of the lab values, he's just got oliguria now, and they just want acute tubular necrosis, okay? It's not prerenal. Now, prerenal azotemia, in contrast, is more subacute to chronic reduction in perfusion, i.e. patients taking high-dose naproxen for 6 to 8 weeks, for joint pain, that can cause, which is an NSAID, that can cause prerenal. Patients abusing furosemide, a loop diuretic, over weeks, that would be prerenal. Patient has congestive heart failure over months to years, okay? That's prerenal azotemia. Fractional excretion of sodium under 1%, BUN to creatinine ratio greater than 20. Acute tubular necrosis, apart from the ischemic etiologies, as I just discussed, also, of course, high yield causes like gentamicin, an aminoglycoside, or amikacin, another aminoglycoside. Myoglobinuria, so if you have rhabdomyolysis, myoglobin is nephrotoxic. IV contrast, okay, so contrast nephropathy. So other important etiologies, toxic ATN, but ischemic ATN, very fucking high yield. All right, so I'll just quickly dance through the other answer choices here. Choice C, interstitial nephropathy, clearly wrong fucking answer. This is going to be an NSAID, beta-lactam, or cephalosporin causing eosinophils, white blood cells in the urine. There can sometimes be blood as well. There can sometimes, about half of questions, you'll get a rash. Okay, but this is going to be a drug, NSAIDs, beta-lactam, cephalosporins with eosinophils in the urine. Wrong fucking answer. Choice B, ABO, incompatibility, wrong answer. We would have a positive Coombs test, okay? So this is just a giveaway. If you were to give blood, let's say, and then patient gets chills, rigors, flank pain, has a positive Coombs test, yes, that would be ABO incompatibility, okay? That's more higher yield for 2CK stuff, for surgery in particular. But you should, for step 1, your basic concepts, you need to know what Coombs test just means. Okay, that's just antibodies against RBCs, and we don't have that here, all right? You know the deal. I'm going to continue making more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.